I'm going to talk about pregnancy and how what happens during those 9 months can really be a look into a woman's future cardiovascular health and why. I will go over changes that occur during pregnancy, risk factors that women may have that increase their risk for having pregnancy complications, and I'll go over the pregnancy complications and why they confer and how they confer an increased risk for cardiovascular disease. And then we'll talk about cardiovascular disease prevention, especially for women who are planning to get pregnant or maybe have gotten pregnant and have had these complications. So to start, I want to go over something called the ASCVD Risk Calculator. And if you came into the Women's Heart Health Clinic and you wanted to get a general cardiovascular disease risk assessment, you just wanted to get an idea of how great your risk is for having cardiovascular disease in the future, we may use something like this. So this is a risk prediction tool, and often we are using these to really take a look at what we believe, depending on all your risk factors, what we believe to be your risk of having cardiovascular disease in the future. The thing about these risk tools is they tend to underestimate a woman's future cardiovascular risk. So I'll just give you an example here of what that looks like. We know that at 50 years old, a woman has at least a 30 to 40% risk in her lifetime of having cardiovascular disease. Well, if we actually plug all of her risk factors into one of these calculators, her risk comes up pretty low. So a 65-year-old woman, most 65-year-old women will look like they are low risk. But if we actually think about their lifetime risk, it's actually quite high. So using something like pregnancy, what happens during pregnancy, could give us extra, just an example and a little look into what her future health may really look like. So I'll give you an example here. So this is a woman who, basically, this is a 55-year-old white female. Her total cholesterol is 200. Her HDL is 45. Her systolic blood pressure is 150. She is treated for hypertension. She doesn't have diabetes, and she's not a smoker. And we actually look at her, if you actually look at her 10-year risk, which is here, her 10-year risk is 4.4%. So in the next 10 years, her likelihood is 4.4% of having a cardiovascular event. So heart attack, stroke, or angina from obstructive disease. But if we actually look at her lifetime risk is actually closer to 40%. And so this big gap here, why is there this discrepancy, and how can we use pregnancy to help us tailor what we tell these women about their future risk? So pregnancy. Pregnancy is known as a stress test for life. And the reason why is because a lot of physiologic and metabolic changes happen during pregnancy. And kind of like when we put you on when we're doing a stress test and we put you on a treadmill, we're really trying to get you to exercise really hard so we can see if we can uncover any symptoms. That's exactly what pregnancy does. So a lot of changes during metabolic and vascular changes in women. It will uncover women who tend to have risk factors for cardiovascular disease in the future, and I'll show you how. Regular changes that happen in a healthy pregnancy, insulin resistance, and this is what we think about when people develop diabetes. Your insulin is supposed to speak to your muscles, but during pregnancy, the muscles are a bit resistant to insulin, and so and a lot of this is to help facilitate glucose transfer over to the fetus. So this is very normal. Hyperlipidemia that goes along with insulin resistance, weight gain, which also can worsen insulin resistance, hypercoagulability. So pregnant women are definitely much more likely to have blood clots, and inflammation happens, hyperdynamic circulation. So pregnant woman has a fetus that that's growing inside of her, so blood volume's increased, cardiac output is increased, and so it's just a much more stressful cardiac workout. However, in women who have pregnancy complications, all of these normal changes become exaggerated and can cause women problems. So this is a model for how pregnancy is a stress test for long-term cardiovascular disease. And I want you just to pay attention to the red line is a population of women who may have some sort of vascular event during pregnancy, like preeclampsia, which is a severe form of hypertension. The blue line represents a healthy population, and the green line represents the threshold of developing some sort of cardiovascular problem, like preeclampsia. So what we'll look at is these humps right here basically represent these pregnancies. And you can see that when a woman who is prone to having one of these vascular problems like preeclampsia, she will manifest it during pregnancy, but after the pregnancy is over, she'll go back to looking pretty normal. She'll have another pregnancy, and again, she'll manifest that same problem again. And again, after pregnancy, it's over, she returns to normal. But the difference between this healthy population and the population that develops preeclampsia during pregnancy, you can see that if people develop it in pregnancy, they're much more likely to develop a vascular problem or a cardiovascular event earlier than a healthy population. And this is what we mean by pregnancy can really be a look at a woman's future cardiovascular risk. So the common complications that we talk about in pregnancy are gestational diabetes. So this is developing diabetes in pregnancy. Typically after pregnancy, it will go away for some period of time. Gestational hypertension, which is hypertension, develops again in pregnancy in women who start their pregnancy normotensive. They have normal blood pressures. And then preeclampsia is a very severe form of hypertension in pregnancy. It's also associated not only with blood pressure, high blood pressure, but also protein being spilled into the urine. Preterm birth, so delivering a baby before 37 weeks gestation, and growth-restricted babies. So these are babies that are smaller than they are supposed to be for their gestational age. And those last four problems are really indicative of some placental problem that's going on. So even though these complications, especially the last four that I listed here, the pathophysiology behind why it occurs is very, very complex and not fully understood, but what is underlying all four of those is a placental problem. So we'll just kind of go over this. It's definitely agreed that there is some vascular dysfunction. The vasculature in these women is not working well or normally during pregnancy. So just to go over some of the anatomy, so these are all the arteries in your body, and if we look at the different layers of the arteries, the one thing that I just wanted to point out is the inner layer that touches the blood, lumen where the blood vessels go through, and all the different tissues of the artery is something called the endothelium. And so in preeclampsia and hypertension and pregnancy, the endothelium is dysfunctional. And it starts with a decreased uterine placental blood flow. So somehow the arteries that are formed in the placenta do not form correctly. And then what happens is blood flow cannot get to the placenta, so the placenta can't get its nutrients, et cetera. So it doesn't get its oxygen that it needs, so it actually releases certain types of factors. And those factors lead to the blood vessels inside the arteries from being dysfunctional. So endothelial cells are very important for vasoconstriction and vasodilation of arteries. So endothelium is responsible for dilating your arteries when they need to be dilated and constricting them when they don't need to be dilated. And what ultimately happens is, because of what happens in the placenta, there's a cascade effect that ultimately leads to hypertension because of this increase in peripheral resistance, because the arteries are not dilating like they should. And what are some risk factors that can predispose a woman to having these pregnancy complications? Things like starting your pregnancy overweight or obese with a BMI of greater than 30, and women who increase their weight during pregnancy above what's recommended. So there are specific guidelines for weight gain in pregnancy, and when women exceed those, they are at increased risk for having these complications. Starting pregnancy with diabetes or even some prediabetes, insulin resistance, being older, having it be your first pregnancy, having a history of some type of preeclampsia, or having a history of preeclampsia, and even starting pregnancy with hypertension. So all these different things can definitely lead to a woman having complications in her pregnancy. So I'm just going to go over a few slides showing what kind of risk these different complications can lead to. So it's pretty startling. So if someone has gestational diabetes, their lifetime risk of having diabetes is almost 8-fold someone who doesn't have any gestational diabetes, and developing it within about 5 years of having gestational diabetes, they can develop their diabetes. So it is very prevalent. So gestational diabetes occurs in about 7 to 18% of all pregnancies, and this is just data right here that I shared with you from a large cohort, a systematic review that included 20 different cohort studies. About 5% of women will develop their diabetes within 6 months of delivering their baby. And then if you wait 3 to 5 years, almost half of those women who had diabetes in pregnancy will develop diabetes. If you follow them out more than 10 years, almost 70% of women will have them. So I think the main thing here is that if someone develops gestational diabetes, is to really inform these women of their high risk for having diabetes in the future. HDP stands for hypertensive disorder of pregnancy, and that includes the gestational hypertension and the preeclampsia. So this is data from a Danish registry. So in Denmark, they follow every single person. Everyone's got a number. They keep track of everybody. So it's very easy to follow people longitudinally. It's very easy to watch and see what happens to them. So what they ended up doing is they followed over 750,000 women, and they followed them for about 6.4 years. And all the women who started their pregnancy had no evidence of cardiovascular disease. And what they found was that women compared with, actually, let me see, women who have, okay, here we go. Women who do not have any hypertension during their pregnancy compared to women who have either gestational hypertension or a mild or severe form of preeclampsia, you can see that having one of these hypertensive disorders of pregnancy can increase your risk of having diabetes, almost 3 to 4-fold, and of having hypertension in the future by somewhere between 4 to 6 times. And if women have preeclampsia specifically, preeclampsia itself increases the woman's risk of having future cardiovascular disease. So you can see that it increases the risk for coronary heart disease by 2 times, 2-fold, stroke by almost 2-fold, and at least VTE stands for embolic disease, thromboembolic disease, and so at least 20% increased chance. And if women have recurrent preeclampsia, so more than one time they've had preeclampsia, they're 7-fold times increased risk for having hypertension. And especially if women have preeclampsia before 37 weeks, it looks like it's even more severe. The risk is even more severe in the future. And this is just to show that this is a graded effect. So women who end up having preeclampsia, if they also have on top of that some other problem like fetal growth, poor fetal growth or fetal death, and these lines represent the different things. You can actually see that over time, women who have had either gestational hypertension or preeclampsia and poor fetal growth or fetal death are much more likely to have cardiovascular events in the future. And this is compared to a normal population here. So the question really is, a lot of risk factors that women have before they start their pregnancy increase their risk for having these pregnancy complications. And so cardiovascular disease in the future really shares a lot of risk factors. So, so one of the things is, the question is, are these women predisposed to having preeclampsia or hypertension in pregnancy because they start their pregnancy with risk factors, or do they develop some problem during pregnancy that predisposes them to having cardiovascular disease in the future? And it's probably both. This is a lot of the data that supports there must be some problem happening in pregnancy that predisposes these women to future cardiovascular disease. A lot of the data comes from looking at endothelial dysfunction that still is happening after pregnancy. So this is data from they use something called brachial artery FMD, which is flow media dilation. So they're really looking to see how well the brachial artery dilates after it's been clamped down for a few minutes. And so normally when you occlude the blood flow from the artery for a few minutes, there's a rush of blood that goes through, and that stimulates the brachial artery to increase. So in people who have preeclampsia, their arteries don't dilate it as well. So they're going to dilate less well than someone who has normal arteries. So you can kind of see in women who have recurrent preeclampsia, they dilate to 0.9%, single episode preeclampsia to 2.7%, compared to the control group of 4.7%. So probably there is something that happens in pregnancy for these women who have these hypertensive disorders that predisposes them to cardiovascular disease in the future. So what has happened is it's become much more well known that these complications in pregnancy can increase a woman's risk. So the American Heart Association put out guidelines in 2011 specifically for women's prevention, and they made a special note that physicians should look to women's pregnancy history to see whether or not they've had any complications, and that this can really help us estimate a woman's lifetime risk, and to refer a woman to a primary care provider or a primary care provider or a cardiologist to really get a good risk assessment. And then also a history of preeclampsia, gestational diabetes, or hypertensive disorder of pregnancy is considered a major risk factor. And what does that mean? So when we look at cardiovascular risk categories, we break people up into different categories, and we break risks up into different categories. People who are at the highest risk for having events are obviously people who have established cardiovascular disease, peripheral vascular disease, or maybe an aortic aneurysm, diabetes, chronic renal insufficiency, or they score high on those risk calculators. Low-risk people really have no risk factors and lead a very healthy life, but most everybody else sort of fits into this category. And so these are the different the risk factors that you've heard about today. But the one thing that's finally been added to this list is women who have a history of gestational diabetes, hypertensive disorder of pregnancy, or preeclampsia. And so in terms of just the risk, it's equivalent to, when you think about smoking, smoking increases a person's risk about 2 times, and it's pretty similar for women who have a history of these particular types of complications. So one of the things that we hope will happen when we talk about cardiovascular disease prevention in these particular women is that we can change the model from looking like this to looking like this. So what this model is you know, if a woman has a complication during pregnancy, if we intervene here with screening, lifestyle modification, and maybe early treatment, we potentially can change that curve for her, and we can actually bring her down so her second pregnancy is healthier. And then, hopefully, in the future, we can actually have her at least not present earlier than normal women in terms of these events. So that's the hope. So if women are planning or are currently pregnant, what can they do? Like we've talked about before, definitely, obviously a healthy diet and exercise. And a lot of reasons why this matters is, since I was telling you insulin resistance is something that naturally happens in pregnancy, when people eat a poor diet and don't exercise during pregnancy, it definitely worsens insulin resistance, and insulin resistance is a risk factor for developing these complications. So both of those things can definitely improve insulin resistance. Not to exceed weight gain guidelines, so there are very specific guidelines, and really trying to talk with your OB about what is okay for me, and knowing what weight is normal for you to gain, and really not trying to exceed that. A large majority of women exceed the weight gain guidelines. And a plan to nurse for 6 to 12 months. So there's more and more data that lactation really does help reduce a woman's risk of cardiovascular disease. So trying to plan to nurse for at least 6 to 12 months. And it does look like this effect is cumulative. So if there are several pregnancies, for her to nurse as many times and for as long as she can seems to help from a cumulative standpoint. So it's not just helpful for weight loss, but it seems to help redistribute fat. And where women distribute fat in the future seems to make a difference in terms of insulin resistance and risk. And for women who've had a past pregnancy complication, what can they do? It's interesting that even though there's a lot of data to show that pregnancy complications confer risk in the future, cardiovascular risk in the future, many physicians don't know this, and so many physicians will not counsel you about this. And also the other thing that often happens is the OB doesn't talk to the primary care doctor, and so the person who needs to transfer that information is really the woman. And so really it's very, very important for women to understand that this is a risk for them if they have these complications, and to really be the one to discuss it with their doctor. Is to get a cardiovascular risk assessment. It's very important for women who have these complications to understand what their risk is, to understand that the pregnancy complication increases their risk, and what else can they do. Like the modifiable risk factors that you heard about today, what difference can you make in those risk factors to bring down your overall risk? And then that's risk factor management. So knowing your risks and then knowing how to bring them down is very important. And early treatment for cholesterol, hypertension, those sort of things. And so this is just looking at the fact that the patient really needs to communicate between all these people, because oftentimes these providers are not necessarily communicating with each other, even though ideally we would be. So in conclusion, that cardiovascular risk, the calculators definitely underestimate a woman's risk. Pregnancy is used, can be used to give us a window into what her future cardiovascular risk will look like, because the pregnancy complications that I talked about today definitely increase a woman's risk for future events, future cardiovascular events, and that earlier cardiovascular risk assessment and modification hopefully can make a difference in changing that trajectory for women. Thank you.